Bismillahirrahmanirrahim. Assalamu alaikum. Thank you very much for giving me an opportunity to rather honor to deliver this lecture on re-irradiation in recurrent head and neck cancer. As he has been introduced me that I'm professor of clinical oncology I was at National Medical University Multan, and this is my university where I joined as a student in 1982 and I retired in 2024 April. So 42 years in this institute, and this is my alma mater. More than two-thirds of my life I have been here. Now, radiotherapy plays a major role in the treatment of head and neck cancer. It's different, maybe concomitant or neoadjuvant chemotherapy followed by radiotherapy. And also surgery is the main part. Both organ preserving, definite chemoradiotherapy and selective post-operative chemoradiotherapy to improve leukoregional control prolongs overall survival. Nevertheless, despite improvement of locoregional therapy, radiotherapy, and after CRT, continues to be waxing problem for 20 to 35 patients. So there occurs recurrence in some cases. As radiation is delivered more precisely with smaller margins, most of the time the radiation therapist and radiation oncologists are more precise and they do try to deliver proper radiotherapy. But at times, they are mistaken and sometimes they do have recurrence in that. So for improved cancer treatment, longer survival due to less chance of distant metastasis, and commercialization of the radiotherapy, this is there. So what to do, where to go, whom to send, how, why, when? So these are the various questions which come when there is recurrence of head and neck cancer. What are the treatment options? For early stage, in new diagnosed cases, surgery plus radiotherapy or radiotherapy. Advanced stage, chemoradiation may be concurrent or neoadjuvant, or surgery followed by radiation and chemotherapy. And very advanced, surgery is less effective, and so we go for radiation or chemotherapy. What is the definition of this? Irradiation is previously irradiated field due to recurrent lesion or secondary primary to get a definite cure. Now, what are the treatment options? Treatment options: salvage surgery followed by re-irradiation plus minus chemotherapy, then re-irradiation plus minus chemotherapy without surgery, then chemotherapy alone, or in case you can't do anything, then best supportive care. The approach should be, again, is a multimodality. There should be, once there is recurrence, there should be multi-modality approach. All people should sit together and decide what to do, what is good for the patient, whether it should be treated or you should give best supportive care. Now, for post-operative re-radiotherapy, the therapeutic ratio is lower than in re-radiotherapy or non-resectable disease. Recurrence may be high, tumor may not recur even without re-radiotherapy for longer time, so it is to be considered in the multimodality team. High-risk patient tumor may recur in sites which are not at high risk. Not having GTV radiation volumes may be larger compared to treating gross recurrent disease. So these are the different factors which are to be considered. So there was randomized trial in which 130 patients with previously radiated with recurrent tumor who underwent surgery and complete macroscopic tumor resection. It was randomized with post-operative 60-day recurrent 5-FU and cisplatin radiotherapy tumor bed, and the second arm was just observation. What was the result? Late toxicity in radiotherapy arm 39%, in observatory arm 10%. And late toxicities were subcutaneous 22%, osteonecrosis 70%, trismus 28%. So these were the various complications which are to be considered before starting re-irradiation in the patients with recurrent head and neck cancer. And these are to be discussed with the patient and the family that these may happen after re-irradiation of the patient. So in these disease-free survival was significantly improved in radiotherapy arm, and overall survival was not statistically different from the observational arm. So again, we have to consider and discuss with the patient that there may be high complication risk, better local control, but no survival benefit. So if you agree with that, you can go for it and offer re-radiotherapy only to the highest risk patient and target only the high risk volume and not the other patients. Then for radiotherapy indication, radical re-radiation is the only potential curative treatment when surgery is not the option. Then post-operative after salvage surgery and palliative conditions. But if there is bleeding or complication, there is obstruction or pain, there is no option other than radiotherapy, then you have to go for the re-irradiation of the. Now consider this, prior radiation, resection, any role of re-irradiation? If the patient has already undergone radiotherapy and then surgery, so is there any condition? Yes, no need of re-radiotherapy, but consider re-radiation in margin positive and extracapsular extension cases, not the other cases. So what to do? Suitable for curable treatment. So if there is, yes, if the patient is suitable, then operative resection, good health status, then salvage surgery, followed by recurrence, and if no, best supportive care and palliative. And if there is suitable curative, then if yes, inoperable, not resectable, then go for radiotherapy. So you have to again consider whether the patient is appropriate to be treated, whether the patient will get benefit out of it, only then you should radiate, otherwise you don't have to radiate. Just give best supportive care. Now, isolated neck recurrence, if there is isolated recurrence, because sometimes you leave the field, you by chance, or there was not in initial status, so there is recurrence in the neck. So then, if there is surgical resection possible, then comprehensive neck dissection, adverse histological features, then you can go for radiation. Otherwise, if it is unresectable, then dose is 60 to 66 gray. Brachytherapy may be the answer to be done, and then concurrent chemoradiotherapy is the treatment of choice. You see this for neck rodal dissection, brachytherapy may be the choice to get it done in these cases. What to look? How to check which is the suitable patient? You check for the comorbidities, performance status, whether the patient is able to speak and swallow function. Then you have to see if there is fibrosis, if there is cardiac stenosis, osteoradionecrosis, or any other toxicity. So we have to consider the dusty check before re-irradiation. Number one, dose received at the bed and overhead and target. Interval between two treatments, the previous and then followed by that. Next one, record retrieval, toxicity evaluation, and multimodality achievement, management. So consider this dirty approach, and then you will consider whether you should treat the patient or not. Now, what is the optimal gap? There is no clear-cut guidelines, but most of the studies, the gap of more than 2 years of the prior radiation, then you radiate the patient. Relative contraindications, less than 1 year previous radiotherapy, lower chance of cure, and high risk for complications. What imaging you do need? Biopsy is mandatory for check whether it is recurrence or not. Then PET CT, then restaging is important. 25% may have metastatic disease. MRI detects local recurrence. If there is metastatic disease, then local treatment is not good for that patient. You should may go for the chemotherapy. What should be the target? Treatment volumes of re-irradiation are in general more limited. Then the smallest possible target is used to minimize the toxicity. No need for elective nodal radiotherapy. Which technique? Maybe IMRT, SBRT, brachytherapy, electron, or IMT. So different variations, whichever is available at your part, you can go for that. Then, IMRT going better. Yes, re-irradiation with IMRT appears to have an improved risk or benefit ratio compared with older techniques. What is the optimal prescribed as cumulative bed dose? Then the maximal cumulative prescribed dose is 140 to 160 gray, not more than that. No clear-cut guidelines. Doses near 60 was planned in different studies. Why results from re-irradiation is not like prior to radiotherapy? Because there is hypoxia. Cells are primarily resistant to the mechanism of giving drug. Cells with acquired resistance. Cells that can be killed by drug treatment. Cells that can be killed by radiation. So there are different reasons. Accelerated repopulation, insufficient drug concentration. So there are various things why we should not radiate. Fractionation schedule, conventional fractionation, 2 gray per fraction is standard of care. There may be hyperfractionation, accelerated fractionation, hypofractionation. So different techniques, different studies show that different techniques can be given. What is it? If you go for hyperfractionation, potential for reduced late side effects, 70 gray at 1.25 twice daily for 6 weeks, and the study, which was done in 2009, shows 66 patients, 20%, 3% had 3-year disease-free survival, and 29% late complication grade 3. And mainly it was dysphagia. Then for hypofractionation, another study done in 2009, 38 patients, 21 to 35 gray, 2 to 5 fractions, high total doses and nasopharyngeal sites improved overall survival, and severe toxicity 11%. Another phase 1 study showing escalated hypofractionation doses, maybe 25, 32, 36, different fractions, and these were given for hypofraction. In summary, tumor-related outcome seems to be similar to series of standard fractionations of radiotherapy. However, SRA series have some much shorter effects, and late toxicity rates are not yet known. Why SBRT for head and neck cancer? Re-radiotherapy. There is great precision and a smaller volume of normal tissue. No delay in chemotherapy if it was pre-planned for adjuvant. Results are encouraging, shorter duration of treatment, already irradiated tissue. SBRT works at more than 4 hours of radiobiology, toxicity almost similar with conventional. This was the study in 2008, fractionated stereotactic radiotherapy as re-irradiation, locally recurrent head and neck cancer. So addressing ORs, vital cord, optic apparatus, brain, then less vital are cochlea, carotid, parotid, and mandible. So in late toxicity, it is impossible to rate late toxicities. So I will omit this. Look at this. The late toxicity, osteonecrosis, spinal cord recovery, or myelopathy. So re-irradiation. The hypopharynx cancer patients planned for radiotherapy and cord dose is 50 gray, which is within limits. Well, but try to decrease the dose to cord possible without compromising the PTV dose. Keep extra safe margins. This is within limits. With time and cord shortage of forgetting irradiation dose, so you have to, can you guess the gender of spinal cord? It is male. With time, it forgets the injury. Girls remember everything and repeatedly spoil your reputation till your death, even a small injury. Do not worry, I will take care. Please provide the dose details of prior radiotherapy. Doctor fearing of radiation myelopathy, please take care. So you have to consider how long the patient is going to survive, and then only then you can plan what to do. These are different. So I'll go for the summary because time is short. Also, carotid artery rupture. This is another thing which may complicate the disease. Period protectors, amifostine. So this can be used, but studies are still going on. I'll go for the role of radiosensitizer, different radios, cisplatin, TBZ, and carboplatin. So, role of chemotherapy as neoadjuvant or concomitant. Summary. Currently, no single optimal treatment scheme for radiotherapy of patient with head and neck, recurrent head and due to widely ranging differences in the local and extent of recurrent tumor. Initial radiation parameter amount of time since prior treatment, degree of existing normal tissue, so toxic effects are more. Then most radiotherapy experiences have targeted the recurrent gross disease with limited margin without elective nodal radiotherapy. The chance of local treatment is higher in patient receiving additional dose of 60 gray. So the prognosis for recurrent treated chemotherapy is poor. The average survival is time being about 1 year. The overall 2-year survival is just 26%. These data demonstrate superiority to those seen in the separate trials of patients treated with palliative chemotherapy. Thank you very much.